Pathology of Fear is a medical documentary series presenting clinically documented neurologic and pathological mechanisms for educational analysis.
The patient is seated in a neurology clinic with a referral note folded on the desk between them and the physician. The note does not mention memory loss. It does not describe confusion, disorientation, or behavioral change. It documents difficulty finding words, increasing pauses in speech, errors in sentence construction, and an inability to repeat phrases that were previously effortless. The patient is alert, oriented, and aware of the problem. They describe knowing exactly what they want to say and being unable to assemble the words quickly enough to speak them. There is no history of stroke, head trauma, or sudden onset. The change has been slow, progressive, and uneven. Language has been failing in isolation. The neurologist begins with structured language testing rather than a memory screen. Naming tasks reveal hesitation and circumlocution. Repetition of multisyllabic phrases breaks down despite intact comprehension. Sentence construction becomes effortful, with omissions of grammatical markers or substitutions that alter meaning. Reading aloud is slowed and inaccurate. Writing shows similar distortions. Comprehension of complex sentences may be impaired even as understanding of single words remains intact. These failures do not fluctuate with attention or fatigue. They persist across tasks and contexts, indicating a stable neurological deficit rather than situational interference. Cranial nerve examination is otherwise normal. Motor strength is preserved. Reflexes are symmetric. There is no tremor, no rigidity, and no evidence of Parkinsonism. Gait is intact. Sensory testing is unremarkable. Executive function outside of language tasks appears largely preserved. The patient follows instructions, understands the testing process, and expresses frustration with their own performance. Insight is intact. The deficit is focal. Neuroimaging has already been ordered. Structural MRI demonstrates asymmetric cortical atrophy concentrated in the dominant hemisphere, often involving the inferior frontal gyrus, posterior temporal cortex, or temporoparietal junction, depending on the pattern of language failure observed. White matter tracts connecting these regions appear thinned or disrupted. Functional imaging, when obtained, shows reduced metabolic activity within language-associated networks rather than diffuse cortical decline. The hippocampi may appear relatively preserved, especially early in the disease course. This pattern does not resemble typical Alzheimer's disease at onset, nor does it match vascular injury or acute focal lesions. The diagnosis under consideration is primary progressive aphasia. Primary progressive aphasia is not defined by dementia in the traditional sense. It is not characterized initially by memory loss, visuospatial impairment, or global cognitive decline. It is defined by the selective, progressive degeneration of the neural networks that support language. Language is the first and most prominent domain to fail. Other cognitive systems may remain functional for years. The disease process is neurodegenerative, but its earliest manifestations are focal rather than diffuse. Primary progressive aphasia is a clinical syndrome rather than a single pathological entity. It describes a pattern of neurodegeneration in which language networks are selectively targeted. The underlying molecular pathology varies between individuals. Some cases are driven by tau protein aggregation, others by TDP43 proteinopathy, and some by Alzheimer-type amyloid and tau pathology. What unifies these cases is not the protein involved, but the anatomical selectivity of degeneration. The disease attacks the circuits that make language possible. Language is often mistaken for a single faculty localized to a discrete cortical area. In reality, it is a distributed system requiring the integration of multiple cortical regions and the white matter tracts that connect them. Spoken language depends on the coordinated function of frontal regions responsible for motor planning and grammatical structure, temporal regions responsible for lexical storage and semantic meaning, and parietal regions that integrate phonological processing and working memory. Damage to any one component destabilizes the entire system. progressive degeneration does not merely remove isolated words or sounds. It disrupts the architecture that allows symbols to be selected, sequenced, and understood. The earliest clinical manifestations of primary progressive aphasia reflect this architectural failure. Speech may become halting or effortful, not because the muscles of articulation are weak, but because the neural programs that generate fluent language are degrading. Words may be substituted, omitted, or rearranged. Sentences may lose grammatical structure. Alternatively, speech may remain fluent but empty, with preserved rhythm and intonation masking a loss of semantic content. In some patients, comprehension fails before expression. In others, repetition breaks down while spontaneous speech remains relatively intact. These differences reflect which components of the language network are failing first. Because memory and reasoning may remain preserved early on, primary progressive aphasia is frequently misinterpreted as stress-related speech difficulty, anxiety, or age-related word-finding problems. Patients are often reassured that such changes are benign or attributed to distraction or fatigue. This misinterpretation delays diagnosis and obscures the progressive nature of the disease. The problem is not retrieval under pressure. It is structural loss of neural tissue within language networks. Unlike acute aphasia caused by stroke, the deficits of primary progressive aphasia do not stabilize. There is no recovery phase. There is no plateau followed by compensation. Language continues to degrade as neurodegeneration advances. Therapy may temporarily improve communication strategies, but it cannot halt the loss of neurons and connections. The disease progresses according to its underlying biology, not according to behavioral adaptation. At this stage, the patient remains capable of independent living. They may continue working, socializing, and managing daily activities. Communication requires increasing effort and adaptation, but it is still possible. This period can last for years. During this time, the disease is active at the cellular level, even if outward function appears relatively preserved. Neurons within language networks are accumulating pathological proteins, losing synaptic connections, and retracting axons. White matter tracts that once synchronized distant cortical regions are thinning. The system is failing gradually, not abruptly. The defining feature of primary progressive aphasia at clinical entry is not confusion or loss of self-awareness. It is the emergence of a specific neurological deficit in an otherwise intact mind. The patient understands the change, recognizes its progression, and can often describe it with precision. This preserved insight distinguishes the early stages of the disease from many other neurodegenerative conditions. It also sets the stage for what follows, as language continues to erode while awareness remains. Primary progressive aphasia is the beginning of a long neurological process in which the capacity for symbolic communication is progressively dismantled. The failure begins in specific cortical networks, but it does not remain contained. As degeneration spreads, the loss of language reshapes cognition, social interaction, and autonomy. What is being lost is not vocabulary alone, but the neural infrastructure that allows thoughts to be translated into words and words to carry meaning. This is not a disorder of speech mechanics. It is not a failure of memory retrieval. It is the progressive collapse of the brain's language networks, driven by irreversible neurodegenerative pathology. The clinical entry marks the point at which this collapse becomes visible. Language is not stored in a single cortical location, nor is it generated by a single neural mechanism. It is an emergent function produced by the coordinated activity of multiple distributed brain regions operating as an integrated network. This network allows abstract concepts to be converted into symbols, symbols into sounds or written forms, and incoming sounds or symbols to be decoded back into meaning. Primary progressive aphasia does not destroy language by removing isolated words. It dismantles the architecture that allows language to exist as a coherent system. At the cortical level, expressive language relies heavily on regions of the inferior frontal gyrus in the dominant hemisphere. These regions are responsible for grammatical structure, sequencing, and the motor planning required to produce fluent speech. They do not store words themselves. Instead, They organize linguistic output, selecting appropriate forms and assembling them into structured expressions. Damage here does not erase vocabulary. It disrupts the ability to construct grammatically coherent sentences, producing effortful, fragmented speech. Receptive language depends on posterior temporal regions, particularly areas involved in lexical access and semantic processing. These regions store associations between words and their meanings. They allow sounds to be mapped onto concepts and concepts to be retrieved as words. Degeneration in these regions produces a different failure mode. Speech may remain fluent and well articulated, but the content becomes empty or inaccurate. Words are used incorrectly. Objects cannot be named or recognized by name. Meaning itself begins to dissolve. Parietal regions contribute to phonological processing and working memory. They allow sounds to be held in mind long enough to be analyzed, repeated, or integrated into longer sequences. These regions are critical for repetition and complex sentence comprehension. When they fail, patients may understand individual words, but lose the ability to follow or reproduce longer phrases. Language fragments under the load of working memory demands. These cortical regions do not operate in isolation. They are connected by white matter tracts that synchronize their activity. The Arcuate Fasciculus links frontal and posterior temporal language areas, allowing information to flow between comprehension and production systems. The uncinate fasciculus connects anterior temporal regions with frontal areas, supporting semantic processing and naming. Additional association fibers integrate parietal contributions. Language emerges only when these pathways remain intact. Damage to the tracts can be as devastating as damage to the cortical regions themselves. Primary progressive aphasia targets this network selectively. The pattern of degeneration determines which components fail first and how language deteriorates clinically. Importantly, the degeneration is progressive and cumulative. Early in the disease, remaining network components may partially compensate for failing regions. Over time, this compensation fails as pathology spreads along connected pathways. The network loses coherence. This network-based understanding explains why language deficits in primary progressive aphasia are not uniform. Some patients struggle primarily with grammar and speech production. Others lose word meaning while retaining fluency. Others experience breakdowns in repetition and word retrieval, despite preserved grammar and semantics early on. These differences are not superficial. They reflect distinct anatomical vulnerabilities within the language network. Language is also deeply integrated with other cognitive systems. Semantic knowledge overlaps with object recognition and conceptual memory. Grammatical processing interacts with executive function and sequencing. Working memory bridges language and attention. As language networks deteriorate, these interactions are disrupted. The failure of language begins to reshape cognition more broadly, even if non-language functions remain structurally intact at first. Crucially, language is not merely a tool for communication. It is a mechanism for organizing thought. Words allow abstract ideas to be categorized, relationships to be articulated, and experiences to be structured. As language networks degrade, thought itself becomes harder to externalize and eventually harder to organize internally. This does not occur suddenly. It unfolds gradually as symbolic representation becomes unreliable. Primary progressive aphasia exposes the dependency of cognition on network integrity. It demonstrates that the loss of language is not equivalent to the loss of intelligence, memory, or awareness. Patients often retain insight, emotional responsiveness, and understanding of nonverbal contexts long after language begins to fail. What is lost is the capacity to translate internal states into shared symbols and to decode those symbols when presented by others. Because language networks are lateralized, the disease often begins asymmetrically. Degeneration typically starts in the dominant hemisphere, producing focal deficits, while the contralateral hemisphere remains relatively preserved. This asymmetry contributes to early preservation of non-language cognitive functions. However, as degeneration progresses, it rarely remains confined. Network disruption spreads along anatomical connections, eroding redundancy, and exhausting compensatory capacity. Understanding language as a network clarifies why primary progressive aphasia cannot be treated by targeting isolated symptoms. Training alternative words or phrases cannot restore a network that is structurally collapsing. Behavioral strategies may temporarily bypass specific deficits, but they cannot replace lost connectivity. The disease is not removing data from a hard drive. It is dismantling the circuitry required to process data at all. This network perspective also explains why primary progressive aphasia differs fundamentally from aphasia caused by stroke or injury. In stroke, a focal lesion abruptly damages part of the network. Surrounding regions may reorganize. Plasticity can be harnessed. In primary progressive aphasia, degeneration is ongoing. Any region that attempts to compensate is eventually affected. The moving target prevents stable reorganization. As language networks continue to degrade, the failure becomes more than a communication problem. It becomes a structural limitation on cognition and social interaction. Conversations fragment. Shared understanding erodes. The patient remains present, aware, and engaged, but increasingly isolated by the inability to use or comprehend language reliably. This isolation is not psychological withdrawal. It is the consequence of network failure. The collapse of language networks is the central event in primary progressive aphasia. To understand how this collapse unfolds, it is necessary to examine the molecular and pathological processes that drive selective network vulnerability. The next phase of the disease unfolds at the cellular level, long before language loss becomes clinically obvious. Primary progressive aphasia does not arise from a single molecular defect. It is a clinical syndrome produced by several distinct neurodegenerative pathologies that converge on the same functional outcome: selective destruction of language networks. The biological driver in each case determines the pattern, speed, and eventual spread of degeneration, but all forms share a common feature. Neurons within language-related cortical regions and their connecting pathways undergo progressive structural failure that cannot be reversed. One major pathological driver is abnormal accumulation of tau protein. Tau is a microtubule-associated protein essential for maintaining neuronal structure and intracellular transport. Under normal conditions, tau stabilizes microtubules, allowing efficient movement of organelles, proteins, and synaptic components along axons. In certain forms of primary progressive aphasia, tau becomes hyperphosphorylated, altering its structure and reducing its ability to bind microtubules. As tau detaches, it aggregates into insoluble filaments within neurons and glial cells. Microtubules destabilize, axonal transport fails. Synapses lose metabolic support. Neurons enter a state of chronic stress that progresses towards cell death. Tau pathology in primary progressive aphasia tends to target specific cortical layers and regions rather than spreading diffusely at onset. Inferior frontal, anterior temporal, and temporoparietal cortices are particularly vulnerable. The selectivity is not fully understood, but it likely reflects intrinsic properties of these neurons, including high metabolic demand, long-range connectivity, and reliance on precisely timed synaptic integration. As tau accumulates, these neurons lose their ability to coordinate with distant network partners. Language processing degrades before other cognitive domains are affected. Another major pathological substrate is TDP-43 proteinopathy. TDP-43 is a nuclear protein involved in RNA processing and regulation of gene expression. In pathological states, TDP-43 mislocalizes from the nucleus to the cytoplasm, where it aggregates into inclusions. This mislocalization disrupts normal RNA metabolism, leading to widespread dysfunction in protein synthesis and cellular maintenance. In semantic variant primary progressive aphasia, TDP-43 pathology is particularly common. Degeneration often begins in the anterior temporal lobes, regions critical for semantic memory and word meaning. The consequences of TDP-43 pathology differ from those of tau aggregation. Rather than producing early motor planning deficits, TDP-43-driven degeneration erodes the neural representations of concepts themselves. Words lose their associations with meaning. Objects can be seen and recognized visually, but their names and semantic attributes become inaccessible. This produces a distinct clinical pattern in which speech may remain fluent while becoming increasingly empty or inaccurate. In some cases, primary progressive aphasia is driven by Alzheimer-type pathology involving amyloid beta plaques and neurofibrillary tangles composed of tau. In these cases, degeneration often begins in posterior temporal and parietal regions involved in phonological processing and working memory. This pattern produces difficulties with word retrieval and repetition, while grammar and semantics may initially remain intact. Over time, the disease spreads beyond language networks into memory-related structures, producing a broader cognitive decline consistent with Alzheimer's disease. Regardless of the specific protein involved, the cellular consequences follow a similar trajectory. Synaptic dysfunction precedes neuronal death. Communication between neurons becomes unreliable as synapses lose structural integrity and neurotransmitter release becomes inefficient. White matter tracts degenerate as axons retract and myelin breaks down. The timing of neuronal firing across the network loses precision. Language processing, which depends on rapid, coordinated activity across distributed regions, is particularly sensitive to this disruption. Importantly, the progression of pathology is not random. Neurodegenerative processes tend to spread along anatomically connected pathways. Regions that are highly interconnected are more vulnerable because pathology propagates through synaptic and axonal connections. In primary progressive aphasia, this means that once degeneration begins in a core language region, it extends to adjacent and connected areas, gradually dismantling the entire network. This connectivity-based spread explains why compensation fails over time. Regions recruited to support failing language functions become targets themselves. The slow pace of degeneration creates a deceptive clinical picture. Early neuronal loss is partially masked by redundancy within the network and by adaptive strategies developed by the patient. Synaptic failure accumulates quietly. By the time language deficits are obvious, substantial structural damage has already occurred. Imaging studies often reveal cortical thinning and reduced metabolic activity that predate overt functional loss. The disease is advanced before it is recognized. Unlike inflammatory or metabolic disorders, the pathological processes driving primary progressive aphasia do not remit. There are no periods of recovery. There is no clearing of aggregated protein sufficient to restore normal network function. Neuroplasticity requires intact neurons and connections capable of reorganization. In primary progressive aphasia, the substrates required for plasticity are progressively destroyed. Attempts at compensation become increasingly ineffective as the disease advances. At the molecular level, the pathology does not target language because language is unique. It targets neurons with specific vulnerabilities that happen to form the language network. High connectivity, long axons, and sustained metabolic demand render these neurons susceptible to protein aggregation and transport failure. Language is lost because it depends on precisely these properties. Understanding the molecular drivers of primary progressive aphasia clarifies why the disease progresses inexorably and why interventions focused solely on behavior cannot halt its course. The collapse of language is the outward expression of a deeper biological process unfolding within cortical networks. How this process manifests clinically depends on which components of the network fail first. That variation defines the distinct clinical variants of the disease. Primary progressive aphasia does not progress along a single clinical path. The outward form of language failure depends on which components of the language network are affected first and most severely. This produces distinct variants, each defined by a characteristic pattern of network degeneration. These variants are not cosmetic classifications. They represent fundamentally different biological trajectories through the language system. One variant is the nonfluent or agrammatic form of primary progressive aphasia. In this pattern, degeneration concentrates in the inferior frontal gyrus and adjacent premotor regions of the dominant hemisphere. These areas are responsible for grammatical structure, sequencing, and the motor planning required for speech production. As neurons within these regions deteriorate, language output becomes effortful and fragmented. Speech slows. Sentences shorten. Grammatical markers such as verb, tense, and function words are omitted or misused. The defining feature of this variant is not loss of understanding. Comprehension of single words and simple sentences often remains intact early on. The patient knows what they want to say. The failure occurs at the level of assembly. Linguistic elements cannot be organized into fluent, grammatically structured output. Speech resembles a laborious construction process rather than a fluid act. Errors are consistent and persistent, reflecting structural damage rather than transient disruption. As degeneration progresses, the impairment extends beyond grammar into speech motor planning. Apraxia of speech may develop, producing distorted articulation and disrupted prosody. These changes do not arise from muscle weakness or peripheral nerve damage. They reflect failure of cortical programs that coordinate the timing and sequencing of speech movements. Writing often mirrors these deficits, with agrammatic structure and spelling errors emerging as language output systems degrade across modalities. Another variant is the semantic form of primary progressive aphasia. In this pattern, degeneration targets the anterior temporal lobes, particularly regions involved in semantic memory. These areas store knowledge about objects, concepts, and word meanings. When they fail, the association between words and what they represent begins to dissolve. Speech may remain fluent and grammatically correct, but it loses specificity and accuracy. Words are substituted with vague terms. Naming becomes increasingly impaired. In semantic variant primary progressive aphasia, comprehension of single words deteriorates. The patient may hear a familiar word and recognize its sound without accessing its meaning. Objects may be seen and used correctly in context while their names are forgotten. Over time, conceptual knowledge itself erodes. Categories collapse. The difference between related concepts becomes blurred. This is not a failure of memory retrieval alone. It is the degradation of the neural representations that give words their meaning. This variant demonstrates that fluency does not equate to intact language. Speech can remain smooth and well articulated while becoming semantically empty. The rhythm of language masks its collapse. Conversations may sound normal at a superficial level, but meaningful information exchange is lost. This discrepancy often delays recognition of the disease, as listeners may not immediately perceive the depth of impairment. A third variant is the logopenic form of primary progressive aphasia. This pattern is often associated with Alzheimer-type pathology and involves degeneration of posterior temporal and parietal regions. These areas support phonological processing and verbal working memory. The hallmark features are word-finding pauses and impaired repetition. Grammar and semantic knowledge may be relatively preserved early on, but the ability to hold and manipulate phonological information deteriorates.
In logopenic primary progressive aphasia, speech is interrupted by frequent pauses as the patient searches for words. Repetition of phrases and sentences breaks down because phonological sequences cannot be maintained long enough to be reproduced. Comprehension of long or complex sentences becomes difficult, even when understanding of individual words remains intact. This pattern reflects failure of the buffer systems that sustain language in real time. Although these variants differ in presentation, they share a common trajectory. Early in the disease, deficits appear selective and circumscribed. Patients may compensate using alternative strategies, relying on preserved network components. Over time, degeneration spreads along connected pathways. White matter tracts linking frontal, temporal, and parietal regions deteriorate. Compensation fails. The network loses coherence.
As variant-specific deficits deepen, boundaries between variants begin to blur. Grammar, semantics, and phonology all degrade as degeneration becomes more widespread. Language output fragments across all dimensions. Comprehension declines. Reading and writing follow speech into failure. The disease transitions from focal network collapse to a broader breakdown of symbolic communication. Importantly, the progression is not uniform across individuals. The speed of degeneration, the order of network involvement, and the extent of spread vary depending on underlying pathology and individual vulnerability. However, the endpoint converges. The language network cannot survive progressive structural loss. Regardless of the initial variant, the capacity for meaningful linguistic communication erodes. Throughout this process, insight is often preserved longer than in other neurodegenerative conditions. Patients are aware of their errors. They recognize the mismatch between intention and output. This awareness contributes to frustration and withdrawal, not as a primary psychological reaction, but as a response to persistent communicative failure. Social interaction becomes effortful. Conversations require patience and adaptation from both patient and listener. The variant-specific patterns of primary progressive aphasia illustrate the dependence of language on distributed neural networks. They show that language does not fail as a single function, but as an integrated system whose components are dismantled in different sequences. Understanding these variants is essential for interpreting clinical presentation and anticipating progression. It also clarifies why no single therapeutic approach can arrest the disease. The underlying pathology continues to advance along network pathways, reshaping language until the system itself can no longer function. The next phase of the disease becomes apparent when misdiagnosis persists and therapeutic efforts fail to alter progression. At that point, the biological constraints imposed by network degeneration become unavoidable. Primary progressive aphasia is frequently misunderstood during its middle stages, not because its biology is subtle, but because its pattern does not conform to common expectations of neurodegenerative disease. Language failure without early memory loss challenges diagnostic heuristics that prioritize dementia as a global cognitive disorder. As a result, patients often pass through multiple provisional diagnoses before the underlying process is recognized. Early symptoms are commonly attributed to anxiety, depression, occupational stress, or age-related word-finding difficulty. Patients may be reassured that pauses in speech are normal, or that communication problems reflect distraction rather than neurological disease. When frustration and withdrawal develop, these responses are sometimes interpreted as mood disorders rather than as consequences of persistent network failure. This misinterpretation delays referral to specialized neurological evaluation and obscures the progressive nature of the condition. Even after neurological assessment begins, primary progressive aphasia is often misclassified as typical Alzheimer's disease. This occurs particularly in the Logopenic variant, where word-finding difficulty and impaired repetition resemble early Alzheimer-type language deficits. However, in primary progressive aphasia, memory storage may remain relatively preserved while language deteriorates. The mismatch between language failure and intact episodic memory is a critical diagnostic clue that is frequently overlooked. Other patients are misdiagnosed with stroke-related aphasia, despite the absence of acute onset or vascular lesions. The slow progression of symptoms contradicts a vascular etiology, but the focal nature of deficits can still mislead clinicians unfamiliar with degenerative aphasias. Functional or psychogenic explanations may also be proposed, particularly when imaging findings are subtle early on. These explanations fail to account for the consistent, task-independent nature of language impairment. Once the diagnosis of primary progressive aphasia is considered, therapeutic efforts often focus on speech and language therapy. These interventions are valuable for maintaining communication strategies and reducing frustration, but they do not alter the disease trajectory. Therapy cannot restore neurons that have been lost or re-establish white matter tracts that have degenerated. Improvement, when observed, reflects compensation rather than recovery. The failure of therapy is sometimes misinterpreted as inadequate engagement or insufficient effort. This interpretation places responsibility on the patient rather than on the biology of the disease. In reality, the limitation is structural. Language training requires intact networks capable of reorganization. In primary progressive aphasia, the networks targeted for training are progressively dismantled. Any gains achieved through alternative strategies are temporary and erode as degeneration continues. Pharmacological treatments have similarly limited impact. In cases associated with Alzheimer-type pathology, cholinesterase inhibitors or other cognitive enhancers may be prescribed. These agents do not halt network degeneration and often provide little benefit for language. In tau or TDP-43-driven forms of the disease, no disease-modifying therapies exist. Experimental treatments targeting protein aggregation have not demonstrated meaningful functional restoration once clinical symptoms are present. The persistence of therapeutic failure highlights a fundamental biological constraint. Language networks depend on precise timing, distributed connectivity, and intact cortical architecture. Neurodegeneration disrupts these prerequisites. The brain cannot reroute language processing indefinitely because alternative pathways rely on the same vulnerable substrates. As degeneration spreads, the pool of available neural resources contracts. As language failure advances, the limitations of compensation become increasingly apparent. Strategies such as simplified vocabulary, gesture use, or written communication may extend functional interaction for a time. Eventually, these strategies also fail as comprehension, production, and working memory degrade across modalities. The disease is not attacking a single channel. It is dismantling the system that supports all symbolic communication. Misdiagnosis and therapeutic failure do not accelerate the disease, but they shape the patient's experience of it. Delayed recognition postpones appropriate planning and support. Unrealistic expectations of recovery create cycles of frustration. Understanding the biological constraints of primary progressive aphasia reframes these outcomes. The disease progresses according to neural architecture, not motivation or intervention intensity. The point at which these constraints become undeniable marks a transition in the disease. Language is no longer partially recoverable or strategically bypassed. Network collapse reaches a threshold beyond which meaningful symbolic communication cannot be sustained. This threshold defines the point of no return in primary progressive aphasia. The next phase is not characterized by sudden deterioration, but by the consolidation of irreversible loss. The point of no return in primary progressive aphasia is not marked by a single clinical event. There is no moment of abrupt collapse, no discrete boundary between partial and total loss. Instead, it emerges gradually as the cumulative effects of network degeneration cross a biological threshold. Beyond this threshold, the remaining neural architecture is no longer sufficient to support symbolic language in any stable form. At this stage, degeneration has extended beyond focal cortical regions into the white matter tracts that coordinate language processing. The Arcuate Fasciculus, which once synchronized comprehension and production, becomes fragmented. Signal transmission between frontal and temporal language areas slows and then fails. Information cannot be integrated across regions quickly enough to sustain speech or comprehension. Language processing, which depends on millisecond-level coordination, loses temporal coherence. Cortical regions that initially attempted to compensate are now structurally compromised. Neurons recruited to support failing language functions have accumulated pathological proteins and lost synaptic integrity. Plasticity collapses not because the brain lacks adaptability, but because the substrates required for adaptation are no longer intact. There are no alternate networks capable of assuming the role of the original language system. The architecture required for symbolic communication has been dismantled. Clinically, this stage is characterized by pervasive breakdown across all language modalities. Spoken language becomes severely limited or unintelligible. Comprehension of spoken language declines to the point where even simple commands may be misunderstood. Reading and writing, which once provided alternate channels of communication, fail in parallel as visual language processing and semantic integration degrade. Gesture and drawing may briefly persist, but lack precision and shared meaning. Importantly, this collapse does not imply loss of consciousness or global cognitive failure. Many patients remain aware of their surroundings and responsive to nonverbal cues. Emotional recognition, basic reasoning, and perception may be relatively preserved. The deficit is specific but profound. The ability to encode and decode symbols collapses, isolating the patient within a world that is perceived but no longer linguistically structured. The loss of language reshapes cognition indirectly. Without reliable symbolic representation, complex planning, abstraction, and social interaction become increasingly difficult. Thoughts may still form, but they cannot be externalized or organized through language. The patient's internal experience becomes harder to share and harder to structure. This change is neurological, not philosophical. It reflects the loss of neural mechanisms that support symbolic mediation. As degeneration continues, non-language cognitive systems may begin to fail depending on underlying pathology. In Alzheimer-associated forms of primary progressive aphasia, memory and visuospatial deficits eventually emerge as degeneration spreads beyond language networks. In Tau or TDP-43-driven forms, behavioral and executive changes may develop as frontal circuits become involved. These changes represent extension of the disease, not its defining feature. The point of no return is reached when communication strategies cease to provide meaningful interaction. Caregivers may observe that attempts at conversation produce confusion rather than connection. Misinterpretations increase. Shared understanding erodes. At this stage, communication shifts from symbolic exchange to management of basic needs through routine, tone, and environmental cues. From a biological perspective, this transition reflects irreversible loss of network integrity. Neurons critical for language processing have been lost. White matter pathways are disrupted beyond functional recovery. Synaptic density falls below the threshold required for coordinated activity. Even if pathological processes could be halted, the remaining architecture would be insufficient to restore language. This irreversibility distinguishes primary progressive aphasia from conditions where language loss stabilizes or partially recovers. There is no latent reserve to be unlocked. There is no dormant network awaiting reactivation. The disease has dismantled the system itself. Reaching this stage does not accelerate the disease toward immediate death. Many patients live for years beyond the collapse of language. Life continues with preserved perception and emotional responsiveness. What changes is the structure of interaction. The patient can no longer participate in linguistic exchange, altering relationships and caregiving dynamics fundamentally. The point of no return defines the boundary between progressive impairment and stable absence. Beyond it, language does not fluctuate or decline further in a meaningful way. It is no longer present as a functional system. What remains is a nervous system that continues to process the world without the capacity to represent it symbolically. The final phase of primary progressive aphasia is not marked by further dramatic loss, but by the sustained consequences of this irreversible network collapse. After the collapse of language networks, primary progressive aphasia enters a prolonged aftermath defined not by rapid deterioration, but by sustained neurological absence. The systems required for symbolic communication are no longer operational. What remains is a nervous system that continues to perceive, respond emotionally, and maintain basic cognitive presence while lacking the circuitry needed to encode or decode language. In this phase, communication no longer functions as an exchange of symbols. Spoken words, whether produced by the patient or directed toward them, lose reliability as carriers of meaning. Tone, rhythm, and emotional cues may still be perceived, but semantic content is fragmented or inaccessible. Familiar voices may be recognized without comprehension of specific messages. The patient's responses are guided more by context and effect than by linguistic understanding. Perception remains intact within the limits imposed by the underlying pathology. Visual input is processed, faces are recognized. Environmental cues are interpreted through learned associations rather than through verbal labeling. The patient may respond appropriately to routines, gestures, and emotional expressions. These responses reflect preserved perceptual and emotional networks, not residual language function. The loss of language alters social interaction fundamentally. Conversations give way to parallel presence. Shared activities replace dialogue as the primary means of connection. Caregivers adapt by simplifying environments, maintaining consistent routines, and relying on nonverbal cues. These adaptations do not restore communication. They create a functional framework within which daily life can continue. Importantly, the absence of language does not imply absence of awareness. Many patients remain conscious of their surroundings and emotionally responsive to familiar people. They may exhibit signs of recognition, comfort, or distress in response to environmental changes. These reactions indicate preserved internal experience, even as the ability to express or interpret that experience symbolically is lost. As the disease progresses beyond the language system, additional neurological impairments may emerge depending on the underlying pathology. In Alzheimer-associated forms, memory and visuospatial deficits often develop. In Tau or TDP-43-related forms, behavioral changes, executive dysfunction, or motor features may appear. These developments reflect spread of degeneration beyond the original network, not recovery or transformation of the disease. Medical care during this phase is supportive. There is no intervention capable of restoring lost language networks. Management focuses on maintaining safety, comfort, and physiological stability. Decisions center on nutrition, mobility, and prevention of secondary complications. The disease itself has reached a stable configuration of loss. The duration of this aftermath varies. Some patients remain in this state for years, sustained by preserved autonomic function and basic neurological regulation. The absence of language becomes a constant rather than a progressing deficit. The nervous system operates within a narrowed range of capability defined by what has been lost and what remains. From a biological perspective, this phase represents the endpoint of network degeneration rather than ongoing collapse. The pathological processes that dismantled language networks may continue at a cellular level, but their functional consequences have already been realized. Language does not return because the architecture required for its existence no longer exists. Primary progressive aphasia demonstrates that language is not an optional cognitive accessory. It is a central organizing system that shapes interaction, planning, and shared reality. When it is lost, life continues, but its structure changes irrevocably. The individual remains present, perceptive, and emotionally responsive, yet separated from others by the absence of symbolic mediation. This is primary progressive aphasia. This is pathology of fear, and this fear is real.